Hello everyone, it's Dr. Atkinson. Today we're going to cover an important and complex topic, cancer of the larynx. This is one of the most common head and neck cancers and carries significant implications for speech, swallowing, and quality of life. Let's walk through the risk factors, manifestations, diagnostics, treatment options, and the nursing process. Overview and risk factors. Cancer of the larynx accounts for about half of all head and neck cancers. Each year, more than 12,000 new cases are diagnosed, and around 3,700 deaths occur. The 5-year survival rate varies widely, from about 32% to 90%, depending on the location and stage of the tumor. This cancer is most common in people over age 65 and is 4 times more common in men. Risk factors are important to remember. Carcinogens include tobacco in all forms, heavy alcohol use, asbestos, paint fumes, wood dust, and chemicals in metalworking, petroleum, plastics, and textiles. Other risk factors include nutritional deficiencies, genetic predisposition, weakened immunity, male gender, and age over 65. It's also more prevalent in African American and white populations. Almost all malignant laryngeal tumors are squamous cell carcinomas, and many patients already have lymph node involvement at diagnosis. Recurrence tends to occur in the first 2 to 3 years, and while distant metastasis is relatively uncommon, new primary malignancies can develop. Clinical manifestations. The hallmark early sign is hoarseness lasting more than 2 weeks, especially when tumors affect the glottic area. The voice may sound harsh, raspy, or lower in pitch. Other early symptoms can include a persistent cough, sore throat, or burning pain when swallowing hot liquids or citrus. Patients may describe a lump in the neck. As the disease progresses, more serious symptoms appear. Dysphagia and dyspnea, unilateral nasal obstruction or discharge, persistent ulceration or foul breath, cervical lymphadenopathy, unintentional weight loss and general debilitation, pain radiating to the ear. Assessment and diagnostic findings. Assessment starts with a detailed history and physical exam, including risk factors, family history, and other conditions. The head, neck, thyroid, and lymph nodes are examined. An indirect laryngoscopy with a flexible scope is often the first step to visualize the larynx and assess vocal cord mobility. If suspicious, direct laryngoscopy under anesthesia allows biopsy and microscopic evaluation. Other diagnostic tools include fine needle aspiration biopsy for lymph nodes, barium swallow for swallowing complaints, CT, MRI, or PET scans for staging and follow-up. Unlike oropharyngeal cancers, laryngeal cancers are rarely linked to HPV, so HPV status doesn't affect treatment. Medical management. The main goals of treatment are cure, preservation of safe swallowing, preservation of useful voice if possible, avoidance of permanent tracheostoma. Treatment depends on stage and tumor location. For early stage tumors, stage 1 and 2 without nodal involvement, options include external beam radiation or conservation surgery like vocal cord stripping, chordectomy, or partial laryngectomy. Laser excision is also effective. For stage 3 and 4 tumors, options may include total laryngectomy with or without postoperative radiation or chemoradiation with organ preservation surgery. Advanced tumors that extend through cartilage typically require a total laryngectomy plus radiation. Dental evaluation is essential before radiation or surgery, and patients must be counseled on the side effects of each approach. Several surgical approaches exist, depending on the extent of disease. Vocal cord stripping removes the mucosa of the vocal cord edge and is curative for some precancerous lesions. Chordectomy, often performed with a laser, removes part or all of the cord. Voice quality depends on how much tissue is removed. Laser microsurgery is highly effective for small tumors, with shorter recovery and fewer side effects. Partial laryngectomy removes one vocal cord and part of the larynx, but preserves swallowing and airway function. The voice is hoarse but functional. Total laryngectomy removes the entire larynx and requires a permanent tracheostoma. The patient loses their natural voice and will need an alternative method of speech, such as esophageal speech, an electrolarynx, or a tracheoesophageal puncture with a prosthetic valve. Complications may include salivary leaks, wound infections, stenosis, or strictures. Radiation therapy. Radiation therapy is another cornerstone of treatment. It may be used alone in early-stage disease as pre-op therapy to shrink tumors or as adjuvant or palliative therapy in advanced disease. The main benefit is voice preservation, especially for small glottic or supraglottic lesions. But there are complications. Mucositis, dry mouth, loss of taste, fatigue, skin irritation, and later, fibrosis or laryngeal necrosis. Patients may require synthetic saliva or humidification to manage side effects. Speech therapy and communication. Because speech changes are life-altering, the patient and family need counseling and preparation before surgery. The speech therapist evaluates communication needs preoperatively. Allaryngeal communication methods include esophageal speech, using swallowed air to create vibrations in the esophagus. It's difficult to master and has a low success rate. Artificial larynx, electrolarynx, a handheld battery device that produces mechanical speech. It's easy to use but sounds robotic. Tracheoesophageal puncture with a voice prosthesis, the most common and successful method, producing speech that closely resembles a natural voice. Nahin nursing process, assessment. Nursing care begins with a full health history and physical exam. Symptoms like hoarseness, sore throat, dyspnea, dysphagia, and throat pain are noted. Nutritional status, psychosocial support, and readiness for smoking or alcohol cessation are assessed. The nurse evaluates communication abilities, coping mechanisms, and spiritual needs. Nursing diagnoses. Key nursing diagnoses may include knowledge deficit about surgery and recovery, anxiety about cancer and loss of voice, impaired airway clearance, impaired verbal communication, impaired nutrition, disturbed body image, risk for low self-esteem, impaired ability to manage care regimen. Collaborative problems include respiratory distress, hemorrhage, infection, aspiration, and tracheostomal stenosis. Planning and goals. Major goals include knowledge and understanding of surgery, reduced anxiety, patent airway and effective secretion management, alternative communication methods, adequate nutrition and hydration, improved body image and self-esteem, independent self-care, absence of complications. Nursing interventions, preoperative education, clarifying misconceptions, explaining the surgery, and introducing communication options. Reducing anxiety, listening, reassurance, guided imagery, support groups, and visits from other laryngectomy patients. Maintaining airway, semi-Fowler position, suctioning, humidification, pain control, and early ambulation. Communication support, establishing reliable alternative communication pre-op and maintaining consistency post-op. Nutrition, IV fluids and enteral feeding until oral intake is safe. Swallow studies guide diet advancement from thick liquids to solids. Taste changes are common due to loss of nasal airflow, but patients often adapt over time. Body image and self-esteem disfigurement and altered communication are major threats. Patients need support in expressing fears and feelings, and encouragement to use coping strategies. Referrals to support groups like the International Association of Laryngectomies or Web Whispers can be invaluable. Managing complications. The nurse must watch closely for respiratory distress and hypoxia, restlessness, agitation, low SpO2, or retractions. These require immediate action, possibly intubation or rapid response activation. Hemorrhage. Monitor surgical drains, suction output, and vital signs. Be prepared to apply pressure if carotid rupture occurs. Infection. Monitor for fever, WBC changes, wound drainage, or subtle signs in immunosuppressed patients. Wound breakdown can lead to fistulas or even carotid rupture. Aspiration. Prevent with positioning, suctioning, and careful tube feeding management. Tracheostomal stenosis. Monitor stoma, secure tubing, and manage cuff pressures. SHASH home and community-based care education begins in the hospital and continues through discharge. Patients and caregivers must learn stoma care, suctioning, humidification, and infection prevention. Safety precautions include protecting the stoma in the shower, avoiding swimming, and alerting barbers or beauticians about sprays or powders. Patients should wear a medical ID bracelet and keep emergency contacts accessible. Rehabilitation includes physical therapy for shoulder and neck exercises after lymph node dissection, speech therapy, and community support. Oral care and radiation considerations. Patients often need frequent oral hygiene to prevent halitosis and infection. With radiation therapy, dry mouth and taste changes are common, so synthetic saliva, sugar-free fluids, and humidification help. Brushing and rinsing several times a day are encouraged. Evaluation and expected outcomes. Desired outcomes include knowledge of surgery and self-care, reduced anxiety and increased hope, clear airway with effective secretion management, mastery of alternative communication methods, adequate nutrition and hydration, improved body image and self-esteem, effective self-care management and rehabilitation adherence, absence of complications like bleeding, infection, or stenosis. That concludes our lecture on cancer of the larynx. Remember, this is more than a medical diagnosis. It's a life-changing condition that requires a holistic approach. Medical, surgical, nursing, and emotional support all working together to promote survival and quality of life.